and welcome. Today we have with us the authors of Medical Marijuana, a clinical handbook, Dr. Samoon Ahmad and Dr. Kevin Hill. Thank you for joining us. My name is Kirsten Walterd. I am from Wolters Kluwer and will be moderating our discussion today. I'm so grateful that Dr. Ahmad and Hill could be with us. Dr. Ahmad has been a practicing physician for over 20 years and has dedicated his professional life to helping individuals find balance in their mental health and physical well-being. He is a professor of psychiatry at NYU Grossman School of Medicine, serves as the unit chief of the inpatient unit at Bellevue Hospital, and is co-author of Medical Marijuana, a clinical handbook. He is also the co-author of the 6th edition of Kaplan and Sadek's Pocket Handbook of Clinical Psychiatry. Dr. Hill is an addiction psychiatrist and director of the Division of Addiction Psychiatry at Beth Israel Deaconess Medical Center and is an associate professor of psychiatry at Harvard Medical School. Dr. Hill has conducted clinical research and written on a wide variety of topics, including medical cannabis, CBD, and addiction to alcohol, cannabis, and opioids. He consults to organizations who seek assistance on cannabis or opioid policy. Dr. Hill earned a master's in health sciences from the Robert Wood Johnson Clinical Scholars Program at Yale. As a leading cannabis expert, he has spoken nationally and appeared often on radio and television on the topics of cannabis policy and treatment, offering a balanced and evidence-based stance on these issues. Now, on to our first question. Why did you two decide to write this book?
Well, I think let me give a little bit of a background on that. Working at Bellevue Hospital in an inner city, serving an indigent population for the last more than 20 years, particularly patients where 70% of them have comorbid substance use abuse. And part of that has been looking at patients through the angle of really substance abuse, which takes, whether it's marijuana, whether it's alcohol, whether it's opioids, all under the same umbrella. And I think over a period of time, seeing so many patients with opioids who started with pain issues and were started on different medications, and over a period of time struggling with it and becoming addicted with it. That was a part of seeing the addiction potential in these patients. But the main issue was looking at the marijuana through the same lens. Because in my private practice, I was looking at patients who were struggling with other issues, anxiety, depression, insomnia. And for them, the issue of marijuana was, it wasn't to this extent help, in some ways interfering with their life. It was helping people with mental illness in Bellevue Hospital. And I started to realize what was the dichotomy here, why patients in an inner city population were struggling versus patients who it was not affecting as much as they, it was like drinking a wine or two over the weekend for them. And I thought to myself, there has to be some balance between the two. And I started to think, how would I collaborate with someone looking at, over a period of time, with cannabinoids, which were being used for pain, for neuropathy, for cancer chemotherapy, for other things. And people were thinking of it, either it was the panacea for every condition or it was the devil's weed. And just somewhere in the middle is the line which defines how do you appropriately use these things. And I found a great collaborator in Kevin, who has worked in policy, who has worked in addiction, who has seen patients, who has spoken widely. And we thought we would come up with a well-balanced book that would give clinicians like ourselves a tool where they could understand what are the risks and benefits, not one or the other. It's science, not belief or politics. And that's where I discussed with Kevin and we decided to write this book.
Samoon and I both know that patients and clinicians are clamoring for evidence-based education on medical cannabis, and patients have a hard time finding evidence-based information on the internet or on social media. And we know that clinicians have been desperate for such information. In fact, recent studies show that up to 80% of physicians feel that they need more education on this topic. So as Samoon mentioned, we wanted to create one source that people could go to, and that's what we did with the book and also the website, cannabistextbook.com.
Thank you. Cannabis has clearly been used by cultures for thousands of years, as you mentioned in the book. Why has research been so limited?
I'll take that one. So there are many reasons for this, but I think they have to primarily do with both the funding for research related to cannabis and the scheduling of the substance according to the Drug Enforcement Agency. And both of those issues are really in the context of this polarizing debate where we have people who strongly support cannabis no matter what. And on the other side, we have people who are strongly opposed to it. And both of these sides at various times are guilty of cherry picking the data. And if you're somebody who is just interested in cannabis and you're learning about it and you've got all these people spreading misinformation about it, you can begin to appreciate how it becomes challenging and people become scared to look at the actual science, and therefore the research has been stymied in that way for a number of years.
What are some of the uses for THC and some of the uses for CBD?
For THC, there are clear indications, and they vary from state to state, the regulations. For example, if you take New York State, for example, you will see that the indications, and the important thing to remember is these are recommendations. It's not called prescriptions. These are recommendations because of the Scheduling 1. Multiple sclerosis, neuropathies, chronic pain, cancer, nausea, vomiting associated with chemotherapy when the conventional treatments are not working, ALS as part of that, post-traumatic stress disorder as well. When it comes to CBD, there is no clear as such guidelines. There's a lot of data that exists at this time, whether it's for anxiety or whether it's for other conditions, whether it's for pain as such. So it hasn't been done as more of the evidence has been for THC compared to CBD. So CBD is more, I would say, anecdotal evidence rather than versus what you are seeing with THC. There's a lot more. And the main issue is what we are seeing now is, in fact, that it's not just one or the other. Because one of the main things to consider is how combinations and what we call as the entourage effect many times of other elements, which is terpenes, terpenoids, flavonoids. And that is where the research actually will ultimately go, which is what is the role of all of these together, a synergistic effect, which can undo or do many of these indications. And there's a lot to be done that way. And the data is not, again, there. So when it comes to CBD, I think everybody is jumping on the bandwagon, as I see right now, to just suggest it for anything. And one part of that is because of the hemp being now regulated after the Farm Bill. If it's less than 0.3% THC, you can use it. So a lot of people have just realized that, okay, I can use it one or the other. But I would tell people that they have to be cautious because CBD by itself, and particularly at high dosages, can be an issue. But let's talk about the CBD from a medical perspective. The only thing that has been actually done, the Epidiolex, which has been approved for seizure disorder, particularly in 3 conditions. One is the Dravet syndrome, tuberous sclerosis is the other one, and Lennox-Gastaut syndrome as well. These are the 3 indications, and that is the FDA approved. Besides that, there is no other indication that has been approved. So people need to really take it seriously because one of the things for CBD is that with higher dosages, liver function tests have to be monitored very carefully. It can cause significant issues, particularly in patients who are using, for example, have a seizure disorder and are using other anticonvulsants like valproic acid. One needs to be concerned. In combination with benzodiazepine like clobazam, one has to be concerned as well. So people need to take this into account, but I'll let Kevin jump in as well.
Yeah, no, as Simoon points out, it's a complex topic. I think when you start from the outside, when you look at the cannabis plant, you have to recognize that there are hundreds of chemicals in the cannabis plant, and there are specific chemicals that are only in the cannabis plant. Those are the cannabinoids, and THC and CBD, cannabidiol, are just 2 of about 140 cannabinoids. And so, as Simoon also pointed out, that we only have 3 FDA-approved cannabinoids right now. So we got dronabinol, and you have nabilone, and then you have cannabidiol. So once you start to think about this, that if we only have 3 cannabinoids and there are 140 in the plant, then you begin to appreciate why people may think that the plant itself might be able to do some things that those 3 cannabinoids cannot.
You mentioned the endocannabinoid system. Where is it located and what does it do?
Endocannabinoid system is actually a complex system which maintains a hemostasis in the body physically. And there are parts of it which are receptors, there are endogenous ligands, which are the endocannabinoids, as well as enzymes, which either synthesize the endocannabinoids or degrade the endocannabinoids and the phytocannabinoids, which are derived from plants. And there are 2 parts to it. The receptors that are important to, which only 2 have been identified so far, is the cannabinoid receptor 1 and cannabinoid receptor 2, which are considered a part of the endocannabinoid system. However, there are other ones I will mention as well, which are in some ways an interplay with the endocannabinoid system. So the CB1 receptor is primarily in the central nervous system and peripheral nervous system, versus the cannabinoid receptor 2 is primarily a part of the immune system, which is mostly in spleen and tonsils and T and B cells and monocytes for that because of the immune response. Now, the main thing about endocannabinoid system is in some ways it works, I would say, in reverse to what we are used to understanding how the neuroreceptor system works. Usually, there is a release from the presynaptic of receptors ending on the postsynaptic receptor, and that's where it interacts. However, the endocannabinoid system is a complete reversal of that, meaning that, in fact, the endocannabinoids are released from the postsynaptic receptor, go to the presynaptic receptor, and one of the important things to remember is that systems like serotonin system, dopamine system, glutamate system, when they go into hyperdrive or there's an excess of it, the endocannabinoid system works like a braking system to keep this in check. So let's say either of those systems are in hyperdrive, the endocannabinoids will sort of activate and put a brake on that. And similarly, you can see what happens in the immune with the cannabinoid receptor 2, which is the immune system. And what does that do? Well, part of that is the anti-inflammatory response that you see. And what is inflammation? In fact, it's a prevention, but however, it can go into hyperdrive. So autoimmune disorders, for example, are a hyperdrive. So the inflammation, in fact, starts to work against the body and starts to damage it. So that is why the endocannabinoids can play a role in that inflammation, and whether it's neuroinflammation or it's inflammation in the body as well. That's why the role in Parkinson's or Alzheimer's, things that are being explored for that. And one of the other things to remember is that with this immune response and inflammation, one of the things that happens is what we call as the cytokine storm. So that is why, in fact, there was a little bit of, I think, excitement with the COVID originally, because cannabidiol, which works on the indirectly, there was some that CB2 receptors, if they are targeted, can put a stop to this surge in the cytokine storm. However, it never came to pass, it never happened. But in essence, the CB1 receptors, CB2 receptors, these are the main receptors. The other receptors to keep in mind that work are orphan G receptor protein, transient receptor potential venoloid system, and there are so many subsets of those. So same goes with G receptor proteins, 55 or 18. Those are the other receptors which are in either in a crosstalk, or some of the cannabinoids also work directly or indirectly. With endocannabinoid system, it's also important to keep in mind that how does the THC versus CBD react with those. CBD as such does not work on either of the cannabinoid receptors. The only time it has any role is in the presence of THC, where it works as an antagonist at the cannabinoid receptor 1. And when what it does is it nullifies some of the effects of THC, whether it's cardiovascular or it is one of the getting the psychotropic effects, versus the THC, which works as a partial agonist at the CB1 receptor, and it can work as an agonist and an antagonist at both CB1 and at CB2 receptors. It's sort of a complex picture, but that's more or less the summary of the endocannabinoid system. And Kevin, if you want to jump in and say something on this.
I won't add anything to that. You did a nice job.
Thank you. Can cannabis be used to treat chronic pain or as an opioid substitute?
So that's a great question, and it's something that we address all the time. We're in the midst of an opioid epidemic, certainly, and part of the genesis of that epidemic has been the overprescription of opioids in various ways, and we're used to getting them if we have surgery or if we go to the dentist, et cetera. So people have, for many, many years, said that when they're using cannabis, they find that they use fewer opioids. So that's been a question that a lot of people have looked at. The answers have not always agreed, and there's a lot of controversy around it, but there have been some important studies that have showed, for example, in the states that have medical marijuana laws, there have been reductions in fatal opioid overdoses. And again, not all of the studies have agreed in those areas, but there have been enough promising results to have people want to look at it some more. And so there have been a number of randomized controlled trials looking at various cannabinoids to treat chronic pain, and many of them have been positive. And so while not all of them have been positive, enough of them have been positive such that if somebody like myself were trying to treat chronic pain in the office with somebody who has done everything their doctor has suggested, they've taken multiple medications, perhaps they've had injections, then there's enough evidence there to have somebody like me consider cannabis or other cannabinoids as a third-line treatment for opioids in that case.
What are some of the most promising areas of research in your opinion?
Well, as Kevin has pointed out, I think what we are seeing now is more evidence pointing towards the role of pain. But some of the areas to look at is from the mental health perspective as well, which is post-traumatic stress disorder, in anxiety conditions, in depression. And obviously, the concern is always when patients have these conditions, you really need to look at any comorbidity that would suggest higher risk of having any psychotic conditions. That's an important thing to keep in mind when we are doing research, as well as in neuroinflammation, because many of these conditions, as I pointed out earlier, discussing the endocannabinoid system, play a role. So exciting, I think, parts of the research could be leading to role in Alzheimer's disease or in Parkinson's disease, both of those conditions, in spasticity, in ALS. We understand their work, but I don't think we have enough data or evidence again. And there are other roles in endocrinology at this point, which is being discovered. There was some role, whether they play a certain role in prevention of cardiovascular. But again, there's a lot of preclinical studies. There's not enough clinical data to point. So if you pick out any organ at this point, you will see lots and lots of preclinical data. Unfortunately, not as much clinical data that's coming up.
And I'm really excited, as I mentioned earlier, I'm really excited about cannabinoids and chronic pain, in particular one type of that chronic pain, neuropathic pain, which is usually associated with some burning in the nerves. And so while there are positive randomized controlled trials that have been published, the strength of the evidence could be much better. And I think that's what we have to do now. We have to have better, more rigorous studies with more subjects over a longer period of time and have people who are experts in the area agree upon the outcomes that we should use in those studies. If we do those things, then I think we could be closer to really getting a definitive answer. Can cannabinoids like CBD be helpful in treating pain? And I really hope that we can find those answers within the next handful of years, because so many patients are desperate for those answers.
I'm sure many of your patients are dealing with the mental strain of COVID. Have you recommended they use CBD to reduce stress or anxiety?
Well, I'll tell you, patients come by themselves, and before they even ask this question, many of them already taking CBD. That goes without saying. And as I had mentioned to you earlier, that it's, again, the strength of the data is not there to really tell them that, yes, it's absolutely clear that it will play a role in anxiety, but people do tend to feel there is some degree of calmness in them. They feel a little somnolent. They feel more relaxed. That's, again, a lot of anecdotal evidence that exists at this time. So it's not like that's the first thing I jump, because I think, as Kevin pointed out, it's the same paradigm whether you're dealing with pain or anything. You go through the regular treatments of what have been substantiated and what the clinical evidence is and what works. And if for any particular reason people are more hesitant, there's a contraindication, there are other interactions with other drugs that pose that challenge. There is a history of other addictive potential where people, if given a particular medicine, can lead to more potential problems. Then yes, CBD is something you can probably entertain at that time. But I would not suggest and jump to conclusion that anytime somebody is coming in with this, you immediately suggest CBD to them.
And I absolutely recommend CBD in cases, as Samoon describes, for what we call treatment refractory anxiety, people who have anxiety that has not responded to the typical first-line medications or behavioral interventions. In those cases, absolutely, I think it makes sense to try CBD. And part of the content in the book that we cover are these areas. Where is the evidence for conditions like treatment refractory anxiety? What has been done? Where is the evidence a little bit weaker than we'd like to see it? And we're trying to provide some guidance for clinicians who are in those predicaments where they've tried first and second line treatments and they're wondering, is CBD something that I want to recommend to my patient?
Thank you. So what are some other risks associated with CBD and with THC?
So with CBD, again, tremendous promise. A lot of it is preclinical, so not yet in clinical trials, as Samoon mentioned. But there are risks, and I think that's something that really has not been emphasized enough. As much as there are a lot of areas where we're really excited about CBD, the level of evidence needs to be improved. And there are cases where people are using it not under the supervision of their physician. And that becomes risky because there are issues related to purity and potency. So there was a study that came out in 2017 that showed that of commercially available CBD products, only 30% were accurately labeled. So that is an issue. There are drug-drug interactions. So people who we see in our practice are often taking multiple medications. Does CBD interact with those medications? There are papers that have come out and are coming out soon that show some of those risks. And then also instances where people will use cannabidiol instead of evidence-based treatments. And that can be risky. So whatever you do, and we know, as Samoon mentioned, a lot of people are very interested in CBD, they're already taking it. But whatever you do, please talk about it with your physician so that you have their expertise can help you, and that's a way to really mitigate the potential risk here, because there is potential risk with CBD and really any medicine that you take.
Right, and I think I'll jump on with the THC, which is that particularly with THC, we know that particularly in adolescents with family history of mental illness, one needs to be really, really concerned. The important thing to remember is that adolescents into their early 20s, in fact, the brain is still developing. The synaptic pruning is taking place until that period of time. And I think there is data to suggest that patients who have a family history are more prone to have a psychotic condition. And in 25%, there's data there that it can sort of lead to schizophrenia in those. So data is sort of fluctuates, but it's fair to say that one needs to be really, really concerned. The second important thing to remember, particularly in adolescence, is that the impairment, particularly in executive functioning, decision-making, cognitive domain, because it really impacts the frontal lobe of the brain. And frontal lobe is which deals with social cognition and many of the things that I just mentioned. And some of these conditions, particularly some of the data, which there's not enough, but what it suggested could be irreversible. And that's something you really, really, really need to be concerned about. So despite all of the advantages and everything, it comes down to, in this population, be extremely concerned. Education is imperative, irrespective of the condition that you are treating, that you need to take it for a really have to be seriously concerned about those implications. And in adults as well, for I think whether it's particularly from a medical perspective, if you're using it in a person who has a history of bipolar condition, a history of schizophrenia, as other conditions, you really need to see what else has been tried and what are some of the conditions and what is the role if necessary. Take an example of someone who in the past has been addicted to opioids or something, is struggling with, at this point, with cancer and uses for chemotherapy and nausea and vomiting, which is refractory. It's a tough call. It's a decision you really need to be concerned about. Or another patient who has in the past struggled with something, whether it's depression or anxiety or another bipolar condition in which there were psychotic symptoms, and at this time requires it again the same caution for those. But what we do see, particularly in patients, psychotic conditions, agitation, irritability, all of those things can be present. So those are some of the things to be concerned about.
Well, thank you so much for spending some time with us. Go ahead.
Go ahead, Kevin.
I was just going to add that certainly with THC, there are acute risks and chronic risks. So if you use cannabis today, it can, important paper came out just last week talking about the impact of cannabis use upon driving. So it can affect your decision-making, certainly. But most, as Samoon alluded to, most of the problems with THC are associated with long-term heavy use. So most people who use cannabis don't fall under that umbrella. I mean, most people are not using it every day for a long period of time. But if you're using it daily or nearly every day for an extended period of time, particularly if your brain is developing, then it's a very risky proposition.
Well, I apologize for interrupting, but thank you both for spending the afternoon with us. I appreciate your answering our questions, and thank you.
Thank you.
Thank you.